Welcome everyone to the Penn State College of Medicine Monkeypox Echo Series. We're delighted to have you join us again today. My name is Jackie. I'm a member of the Echo team, and I'll start us off with some brief announcements and introductions. I also have two of my Echo colleagues online, Emily and Kara. So if you have any problems or questions throughout, feel free to private message them, and they could certainly help you out. If you've not already done so, please put your name and email address into the chat for our record keeping, especially if you're logged in with a name that's not identifiable. If there are others who are joining with you, please include their names as well. We ask that you stay muted unless you're speaking. You can use *6 on your phone or the microphone icon to toggle your microphone. You can also use the chat for communicating throughout the series or the session. Please remember that when we discuss cases that no PHI or personally identifiable information is allowed. We are recording these sessions for educational and quality improvement purposes, and we'll share all materials after the session. In the spirit of Project Echo's All Teach, All Learn, we're always on a first name basis during our sessions. So today we're going to have a brief flash talk on monkeypox risk factors and stigma by Jarrett Sell. And that will be followed by a case presentation and discussion. Adam Lake contributed a lot of the details around the case, and Casey Pinto will be facilitating and walking us through that case. During the presentation and the case, feel free to put any of your questions or comments into the chat. We do have a team of specialists online, and they're going to help field questions. But remember that Project Echo is all teach, all learn. So everyone is encouraged to share both questions and answers. And due to the nature of the monkeypox presentation, please note that in the case, some images may be graphic. So before we start with our session, I'm just going to ask our hub team to introduce themselves. I think everyone may be here, maybe not. I'm kind of looking through the chat. So when I call your name, just go ahead and unmute and tell us who you are and your role and your expertise in this series. So let's start with Casey.
Hi, I'm Casey Pinto. I'm an assistant professor at Penn State in the Department of Public Health Sciences in the Division of Epidemiology, and I also work as a nurse practitioner in an STD clinic and for infectious diseases.
Thank you, Casey. And how about Jarrett, who'll be our guest speaker?
Good afternoon. Glad to join you today. I'm a family physician also with Penn State and see patients primarily in Harrisburg. I also serve as medical director and see patients at Alder Health Services in Harrisburg, where we do a lot of STD testing. I do a lot of HIV care management, treatment prevention, and happy to join you today.
Thank you. Adam, I see that you've joined us and you'll be helping us go through our case. So do you want to go ahead and unmute and introduce yourself?
Sure. Yeah, thanks. I had some technical difficulties here. I'm a family doctor in Lancaster, do a lot of HIV, STD work, gender affirming hormone therapy, and we've been kind of leading stuff around monkeypox here locally in Lancaster.
Thank you, Adam. I don't know, Emily, Kara, has Kat joined us?
I have not seen her yet.
Okay, so when Kat Paulus joins, I'll have her introduce herself in the chat. She was here the last time. And you may also remember that 2 weeks ago when we first started, Gavin McGregor Skinner is part of our hub team of experts. Unfortunately, he was called away unexpectedly at the last minute for some sort of Legionnaire's outbreak investigation. So he's not joining us today, but he will be missed. So with that, I'm going to mute. Emily, I believe, is going to share slides, and we're going to turn it over to Jarrett for our flash talk.
Is everybody seeing the slides okay? Fantastic. Jarrett,
Yes.
I'll turn it over to you.
Okay, thank you. So I was asked to speak about stigma and risk factors in the context of monkeypox. Next slide. No disclosures that I have specifically. Hopefully just in a few minutes, go through some risk factors, epidemiological data, talk about stigma within this context as well, and how we might thoughtfully consider ways to reduce stigma for those at risk or affected by monkeypox. Next slide. So what are the risk factors for monkeypox transmission? Close contact is the primary risk factor. So, close contact with the monkeypox lesions themselves, body fluids, respiratory droplets, or contaminated materials are the primary means of transmission for monkeypox. Next slide. Somewhat intentionally, I separated out, kind of other risk factors that are sometimes included, really are more, I think, epidemiological data. And so for those of you who have been paying attention to the monkeypox outbreak, I suspect you may be aware of the recent New England Journal of Medicine article kind of detailing over 500 folks affected by monkeypox internationally in 16 different countries. And if we look at the data from those that have been affected in the study, 98%, so really the vast majority were gay and bisexual men, 75% white, quite a high number, so 41% had HIV, and of those, 95% were, had an adequately suppressed viral load and were on HIV treatment. The median age was 38 years of age. And so sexual transmission in this group, really was the primary means for transmission, with about a third having other sexually transmitted infections as well. So I think this really shares some important information, in terms of the epidemiological information that we have so far. Next slide. Also, if you go to the CDC, you can see some of the data, which looks fairly similar in terms of the age range, so 20s to 50s, kind of tapering off as you get older, predominantly men, if we're looking at gender and age. Next slide. And then in the US, in this data set, there is a bit more diversity compared to the one shared in the New England Journal article, where there are significant numbers of those that are Hispanic or Latino or Black or African American that are represented by the green and the purple portions of the bar graph here, with white being listed in blue. Next slide. So as we think, we've looked at, who's getting monkeypox and some of the epidemiological data, what the specific risk factor is for transmission, how do we incorporate or think about stigma within this context? Just to define it, to start off with, stigma is negative attitudes or beliefs about people with a specific condition. In this context, monkeypox, we can certainly apply this definition to other stigmatizing health conditions as well. And it's prejudice that comes with labeling an individual as part of a group that is believed to be socially unacceptable. And then discrimination is, the behaviors, the actions, the things that we do as a result of those attitudes or beliefs. Next slide. So in thinking about how stigma can affect healthcare and what some of the potential harms would be, as we look at, how do we intentionally talk about, educate, prevent, vaccinate, treat folks in regards to monkeypox, certainly applying a lens of stigma can be very helpful. The graphic on the right is in relation to HIV care, which I think historically is a really good comparison, for thinking about how stigma affected the HIV epidemic early on, and access to treatment and care. The blue graphs on the graphic on the screen, are the continuum of care in HIV treatment. So not specific to monkeypox, but I think is a nice graphic that helps you visualize some of the challenges as we think about getting folks who may be at risk into care, diagnosed, treated if necessary, thinking about getting folks vaccinated or prevented to really, stop an epidemic. These are the steps that it takes. And, stigma certainly can have an influence and likely is a contributor to folks not showing up for care, perhaps not having adequate access to care or treatment, as stigma and discrimination can affect healthcare utilization, provision of clinical care, delays in testing. And importantly, continue to perpetuate health disparities that may already exist for individuals or groups of people that can affect broad health outcomes. And again, using the HIV epidemic to provide some context for what we might think about intentionally doing to reduce stigma for monkeypox. Next slide. So the CDC does have some recommendations borrowed from the reference listed on the bottom of the slide, thinking about the importance of language and how we communicate about this public health issue. So really talking about it as an issue, monkeypox being something important to all people in the United States and internationally. Focusing, you may have noticed that instead of listing males, men who have sex with men as a risk factor for monkeypox on the initial slide, really focusing on contact.
We're trying to expand over to like the surrounding areas, so that's where we are, but we don't have a space here yet.
Thank you. Sorry for the interruption. And so I think I was intentional in thinking about that initial slide on risk factors, trying to communicate that contact is the primary means of transmission, which is perhaps a way to destigmatize, sexual behavior, sexual transmission, and have, more folks really focusing in on and adequately educated about how monkeypox can be transmitted. I think as we educate our patients that we interact with, our communities, thinking about talking about this as a problem that affects us and we, not as about those people or people that do those things, as intentional ways to use non-stigmatizing language. Also, as we're sharing information on social media and other places that are important as for medical education, using non-sensationalistic language and images, using images that are positive, diverse, credible, and really focusing on the nuts and bolts of prevention and symptom recognition and treatment to educate and target folks who may be at risk, but in a way that, again, doesn't further stigmatize or discriminate against a certain group of people. Next slide. So in thinking about how this plays out in practice, this image, if you can hit the next two advance buttons, please. I think frequently in practice, I find myself, trading hats and kind of thinking about some of the epidemiological data that we have, and then also being, caring for a particular person and individualizing that care. So it may be true that monkeypox has at this time mostly affected men who have sex with men. So that may be a more common conversation, that I would have with patients. And, the guy that I saw this morning, had already been aware, had gotten his vaccination, was concerned about this. And so had received the medicine or the message adequately. But I think the balance, in trading that off is it doesn't mean that every, male who has another male partner, is themselves at risk for monkeypox. And I think we have to be careful to avoid, labeling groups of people and furthering some of the stigma that can occur. You can hit the next three advance buttons as well. And I think the other hats that we frequently wear, really are ourselves being often part of a community, having some awareness of some of the issues that are affecting the community that we care for. Of course, we're always influenced heavily by, our own experiences or anecdotal experience, the last patient that we saw, the last person who we worried about monkeypox, for example, can really influence the next patient that we see. And then, all of us certainly have those implicit and biases that influence how we talk about issues, the care and treatment that we provide. And so my encouragement with this image, with this slide, is to think about, how we talk to patients, how we talk to the community, how we think about providing, care in a non-stigmatizing way that continues to target those at risk, those that may be needing improved access to care, et cetera, to really address the monkeypox outbreak that's occurring. Next slide. So, I think continuing to target and test and prevent for those at risk, but doing so in a way that combats stigma and discrimination, I think is a reasonable goal. And certainly I hope, there are many resources out there to think about the ways that we talk about monkeypox and other healthcare issues using non-stigmatizing language that I hope are helpful for you to consider. Thank you. I think that was the last slide. So references are there. Happy to answer any questions or move on to the case.
Yeah, if there are any questions, feel free to unmute or put questions into the chat. I'll wait a few minutes, see if there are any while we start to transition to our case. And again, that will be Casey and Adam. And I do want to mention that Kat was able to join us. Thank you for making the time. I know you have a busy schedule. All right, well, Casey, if you want to pull up your slides, I'll kind of watch the chat if any questions come in. And yes, I'm seeing them the right way, so I'm going to mute and let you take over.
Hi, thanks so much. This is a little bit different of a case presentation. If you guys have been on these echo sessions before, Adam Lake, who introduced himself earlier, shared this with us, and I'm going to take the lead in presenting. But I do want to mention that this case was, because he had so many great details, became a very long case, and we cropped it to meet more with the topic. And what we'll likely do is use kind of the second half and the big clinical decision making in the future for one of our future series. So to start, a couple things. The two that we tied most in with Jarrett's presentation is encouraging this open patient-provider communication and minimizing stigma and implicit bias. But we also want to identify risk factors for monkeypox acquisition. So this is our patient. He is in the early 50s and he identifies as male and was biologically male. He has a small lesion on his finger and he actually is well known to the practice. So instead of presenting to the office, he sent this through the patient portal to get some advice. So this is where we have our first poll. I'm hoping everyone can see that picture. And I kind of want to get a feel for where everyone thinks their diagnosis is. So go ahead and answer.
My goal is to always get a little over close to 60%, if not 75 or at 51. I'll wait another few seconds and we'll end this one. And I'll share the results. All right, we're up to 54%. Let me end this and I could share. So you should be seeing the results right now. Are you able to see those, Casey?
Yes.
Okay.
And I believe that the audience can as well. And this is kind of what I expected, right? We didn't give you guys much history to work with. And judging by the picture, it's not very indicative of much of anything. So superficial trauma kind of won. And we'll Did you guys see the results?
Yeah, they popped up.
Oh, okay. So I'm going to stop sharing and close this. And then move on. So the differential diagnosis we talked about, and actually monkeypox was pretty low on the differential diagnosis at the practice, just based on what this looked like, even though they had a good history for the patient. So the management in the office was reassurance and follow up if lesion worsens. So big questions here, and you guys can chime in or you can pop up in the chat. What further questions would you have asked at this visit, or what history would you have liked to have before kind of coming up with your differential diagnosis?
Casey, are you able to see the chat?
I was trying to get it open.
Okay,
So
so far,
associated symptoms.
Thank you.
Yeah, exposure. How does the lesion feel? Is any burning or pain there? Is it itchy? These are good things to follow up on.
All right, so the patient had denied any associated symptoms. How long has it been there? Some of these I don't know the answer to. Adam may have to chime in, but what I can.
Sorry, it's been 3 days since it's been there.
Okay.
No known trauma. At least not that I remember him reporting. Trish, I think you saw him as well.
All right, so I'll move on. The other big thing we wanted on the patient was a history, but they are known to this practice. So the providers did have this, but we moved it out of order to kind of see how it would change people's perspective. So they didn't have any recent international travel. They do live in the US. They are a cisgender male, gay identifying, married, but they have an open relationship. No history of sexually transmitted diseases, and their last sexual partner was about a week ago. So does this history change your diagnosis at all? And sorry, I'll wait till we get a little more till I have my follow-up question.
I'll give another few seconds. Kind of hitting about 50-some% on these responses today. All right, let me share the results.
All right, so it looks like the majority of you chose no. And a little over 25% chose yes or not sure. So if anyone wants to share maybe why that they would change their diagnosis based on this. Or why not? You can unmute and just talk if you're willing. There's no right answers. Anyone from our hub team that would or would not have changed their answer in response to this want to chime in?
Realistically, I don't think the lesion looks terribly suspicious for anything. And so I don't think if I were seeing that picture and that history that it would change my management.
Sandra kind of mentioned what I keep thinking with this, that it takes a little bit of suspension of disbelief that we're in a monkeypox echo and we're not presenting a monkeypox case. But I think that still, it even though we were thinking about it when this guy showed the picture, it really doesn't look like it very much.
All right, and somebody did mention that the relevance of that social history with the last sexual partner 1 week ago and the onset of the lesion might have them. They didn't say whether or not they would have changed their decision, but that might be one of the things to maybe increase suspicion. All right, but we'll move on. So now this is day 3. The patient continues to deny any systemic symptoms, but the lesion is now getting bigger. They've reached out again with another portal message, and they're saying that they're concerned about monkeypox at this point in time. So one of the things that, at least in practice for me, if a patient comes in and they're concerned about something specific, I tend to be more concerned about their specific thing. So I'm wondering if anyone else has this or if this is just something I personally do. So now that they're concerned about monkeypox, has this changed or made anyone think that put this higher on the differential besides just the presentation of the lesion?
So, I mean, I can comment because I received this message. And it's certainly the fact that the patient was concerned about it raises concern. And, you know, especially with something that's new that we don't have incredible patterns because we just don't have enough data. So, you know, I think my threshold is pretty low to test, especially if someone is really concerned about it. And I mean, the lesion has obviously changed since the last time we saw it, and it's got the umbilicus now, so like, or it's umbilicated. So I, you know, advised him that we needed to get it tested. But I do think that even if it hadn't necessarily looked like it, if he was super concerned about it and we don't have the best data to support exactly every single presentation, I think I still would have tested him.
I think
and
the
there's
counterfactual things important to think about too. If this was just some guy with, you know, no reported sexual exposure, this is just, you know, 30-year-old guy comes in and is like, hey, this thing keeps getting bigger on my finger. You know, I'm not, well, in the context, I'm like, oh, now it looks like monkeypox. But, you know, if it was somebody that, you know, wasn't reporting any exposures, I'd think like, okay, we're starting to get something that maybe I need to, you know, lance because it's going to turn into paronychia.
Yeah, and there's some comments in the chat. One of them, Jarrett said, this looks more like monkeypox, just looking at the lesion, but other people are commenting on why they're suspicious of it being monkeypox. Did they feel that there was exposure? And then they'd also be concerned that maybe they're holding back some information that perhaps they're uncomfortable sharing. And that may be something to do with the level of comfort of patient disclosing, which we all know is always a barrier. So our differential remained the same on this case, except if you saw the first differential, even though we put it in the poll, we didn't have monkeypox because the lesion was not very suspicious for monkeypox. And, you know, just based on the patient's no other clinical symptoms, we didn't believe it was. So at this point, they did refer, as Trish mentioned, they did direct for testing. When they got to urgent care, the only additional symptom was this left armpit soreness. The lesion was swabbed, the patient was asked to isolate, and they did question about any symptoms in their recent partner, which was denied. The recent sexual partner that was extramarital as part of the open relationship did not disclose any symptoms and said that they had no signs or symptoms of monkeypox. So now, knowing that their exposure had no signs or symptoms of monkeypox, and their current marital partner has no signs or symptoms of monkeypox, does anyone still think this is monkeypox? Do you think that we should have isolated at this point in time?
I mean, I think this is a good question in terms of management. I mean, looking at it, it's like, okay, I'll swab that for monkeypox, and especially, you know, it's not classic. It's not a whole bunch of spots. It's not genital or anorectal. So it, you know, it can feel like a little bit of a stretch. Then, like, okay, we're swabbing this for monkeypox. Am I telling this person that they can't work for the next 3 to 4 days because of this little thing on their finger that I happened to swab for monkeypox? Now, this is somebody that we didn't go through it in the social history, but I think that someone's employment ends up being pretty relevant to how we handle this too. And this is somebody that, you know, could feasibly work from home. This isn't somebody that, you know, is living paycheck to paycheck, and if they miss work, it's a huge deal.
And someone asked how long it takes to get the test back. It depends on if you send it to the state lab or if you send it to one of the other diagnostic laboratories like Quest, who's currently running them. In this case, it took about 3 days to get the test back. But sometimes if it goes to the state, it may take longer, especially if it falls over a holiday weekend.
And one other thing to note, to my memory, I think he had not had sex with his partner since these symptoms started. So obviously they were still living in the same household and everything like that. And you know, it's not necessarily in a location that it might be a big deal with sex, but you know, I think we didn't have that exposure. So.
All right, so we're jumping ahead a couple days to day 6. The patient's still denying any fever or systemic symptoms. The first lesion on their finger, will actually be on the next slide, but we're going to do the poll first, is a little bit larger and is causing more pain. And now they have a new lesion on that first picture is the wrist, the buttocks, and the scrotum. So seeing the placement of these lesions, we'll pop this poll up and see what your most likely diagnosis is now. We're almost at 50%.
Almost. All right, there we go. I am going to stop and I'll share the results.
So overall, it's overwhelmingly in support of monkeypox, with 96% of you saying that it is. And I asked this next question on the poll. I asked this next question just because I want to get a feel. So if this patient were monogamous or even female and they worked at a daycare, how would this change your diagnosis, noting where the lesions are? We're at 49%. One more person.
There we go. All right, I'll share the results.
All right, so we have a broader differential in a patient who is non-MSM or female. And I kind of want to pick your brains at why you think that might be, and then maybe talk a little bit about another case that we know of through Gavin, who's unfortunately not here today.
I think it's also important to note that here we're seeing kind of a lesion on the buttocks, a lesion on the penis. This is something that, and unless you're routinely doing a full body skin exam, these are not ones that are going to jump out at you unless the patient's pointing them out. You might just have the wrist and the finger.
Yeah, so one of the comments in the chat is that common pediatric viruses like hand, foot, and mouth, which was second to monkeypox for this breakdown, is more likely in a daycare setting. So the fact that this person worked in a daycare setting kind of changed their perspective, and maybe the rest of the factors did not.
And also thinking about a little bit more aggressive testing of things. I mean, if somebody has herpetic Whitlow and then they have all these, newborns that they're constantly kind of touching sensitive areas, that's something that, takes on a little bit of a different transmission risk too, as opposed to somebody that, works from home and just touches their keyboard.
We have a much quieter group than last week. Any other comments on why you may have changed based on if someone were MSM or not? And if they worked at a daycare? So we were actually hoping to get this one case to use, but they hadn't published it yet. But we know through kind of working with Gavin that we had a young female who worked in a daycare center with a rash that only presented on her foot. And when she first came in, she thought it was ant bites and actually didn't equate it to monkeypox at all because she was not sexually active and had no real risk factors, but she worked in a daycare center. And it turned out that she did actually have hand, foot, and mouth, and that those lesions on her foot were her presenting lesions for her hand, foot, and mouth. And we don't have the rest of the details on that case, but it's important.
She had hand, foot, and mouth, or she had monkeypox?
She had monkeypox. Yeah. And so it's kind of important to think about stigma both ways, because now we have this MSM population that we're targeting, and we're saying, hey, this is the population that we're thinking about when it comes to stigma and when it comes to this disease. But we also have other populations where we'll put a different differential up higher, and we should also be considering monkeypox because these lesions are so indicative of other diseases.
The other thing that I might have thought of in a different patient, just thinking about the distribution, is potentially scabies.
All right, so in this case, the majority of you were right. The monkeypox did come back positive. Obviously, we're a monkeypox case series. I did kind of want to present one that wasn't monkeypox, but I didn't think it would be appropriate. So the patient did come to the office. They did try to IND, got a little bit of serosanguinous fluid, but then they added additional STD testing. So that's where we'll stop this case. This case does progress, and we may use this in future series. I'm actually hoping we do, because it's really interesting from quarantining perspectives. But someone did just mention in the chat that these additional lesions make herpetic Whitlow less likely, and it's not a typical presentation for hand, foot, and mouth, which is usually febrile. Yeah, so. In summary, and we still have a little bit of time, which is great, but we wanted to overall kind of talk about different risk factors for monkeypox. We wanted to encourage this open patient-provider communication, and we wanted to minimize stigma. Before we move on, and I asked Adam to share another case that he had quickly, I was wondering if Kat had any input on this case, because she really helped us craft these slides as well.
Thanks, Casey. I just think it's important, because we're still learning a lot about the presentation of monkeypox, to really probably test more than we need to up front, as we're still getting a handle on how these things present, particularly in risk groups. And we've had a couple of cases here that we've been involved with where really, looks like a typical acne lesion or something along those lines, but we've tested and found monkeypox because, high suspicion based on risk. And so that's something just to keep in mind as we learn more about this outbreak.
And then Adam actually had a case that we all thought really highlighted stigma, but it was after we had prepped our slides and we had to get them approved by the main echo series. So I asked him just to kind of talk about it a little bit now. And since we have more than enough time, we'll move on to that case.
So this is a younger African-American guy in his 30s. He's married. He has a younger child. His first contact with healthcare locally was about 1.5 years ago, and he was in a lot of mental distress. He was had mentioned to his wife about starting to think more about his sexuality and kind of, am I more attracted to men, and just kind of concerned about that. And he didn't have the best response to that, both internally and with his support group, and kind of sought some emotional support, and was referred for therapy, started on SSRI and then disappears for a while. He then shows up at urgent care about a month and a half ago, and has multiple pustular lesions around some on his genitals. And after a question or two, he's like, yeah, I'm very concerned about monkeypox. He had kind of separated from his wife briefly and did have a brief relationship with another man, and ended up being told by this partner that, oh, hey, I just got diagnosed with monkeypox, you should get checked. And this guy already had symptoms, already had a rash. So he got himself to go to urgent care, got tested. In between having this encounter with this other man, he reconnected with his wife, who happened to be pregnant, and they did have sex. And then he developed the rashes. He ended up getting diagnosed with monkeypox. During all of this happening, I mean, this was when it was taking 5 or 6 days to come back from the Department of Health. He ended up getting kind of kicked out of his house. His wife kind of moves somewhere else. He's kind of living with his young son in a hotel. There's a lot of kind of vague pieces to this. He's in a lot of pain. I end up being able to start him on TPOXX, and we follow up a few times. Seems like he's doing well. He actually has a visit afterwards with somebody from his PCP's office. It was just a telephone visit, but he says everything healed up. It's all going fine. We did some mental health screening at the time, and it was, everything sounded fine. And then 2 weeks after that, contacted by Department of Health because the coroner found him dead, assumed to be suicide. That's kind of all I really know, but kind of a sad case. Is it, kind of just with the limited information that we have, this is a guy that's already kind of struggling with some internalized stigma, not quite knowing how to handle that within his relationship, and had already kind of felt depressed about that. And really if he had just had a sexual encounter with somebody while he was on a hiatus from his wife and nothing came of it infection wise, he might not have necessarily disclosed that. Maybe he would have, maybe not. A little bit of conjecture there, but this is something that really kind of outed him, that he has monkeypox, and probably felt really bad about it. And I really didn't get into a whole lot of mental health counseling around it. I mean, I was more just talking him through all the paperwork and spending my 2.5 hours of time that I didn't really have to get him Mpox. So that was my focus for the visit, and just trying to get him through that. So I'm not sure if it's something that we could have identified or picked up on earlier, but this is something that certainly with the association with MSM folks, it's something that, if you have monkeypox, it's not because you used the wrong toilet, it's because you were with somebody. So I think it was kind of a illustrating example of kind of this playing out on a different level.
Adam, I think that I think this was the case, but that you reported it to the CDC as a potential side effect, like suicidal ideation. Obviously, he has a lot of complex social things that could have led him to that, but he didn't have a history of SI that was at least previously reported. So
I did find a time that he was 302'd after an argument with his wife. But that was something that I dug around and found out afterwards. That was several months before, and he wasn't actually admitted. He just went to the ED and was like, no. I hadn't even, apparently there wasn't even him saying anything. It was just, they had an argument. He left. She was very worried about him. So there was that concern mental health wise, but that was something that was kind of an outside records that I was digging around because of this. It wasn't kind of upfront all over his chart. Yeah, that came to me. I didn't report it to the CDC. The Department of Health kind of learned about it and connected the dots, and then reached back out to me to say, like, hey, we need to talk about this case because somebody's died after taking Mpox. And several weeks after finishing the course, it's kind of hard to point to Mpox or monkeypox as the cause, but certainly it's not a good outcome. It's kind of a sad scenario.
Jarrett, I was wondering, I don't want to put you on the spot, but you work with a very similar population at Alder. I was wondering if you had any comments, any thoughts about stigma, depression, this possible outing and relationship.
No, I think that is an unfortunate story, but I think reflects, many of the sexually transmitted infections, many of them that may be more prevalent in, certain communities, particularly men who have sex with men. HIV stigma still exists and is a problem for people. I think that we have great options for treatment and, great ways to hook folks up, but I think that importantly in caring for people, asking how they're dealing with a recent diagnosis. So it really highlights, I think, that if we're seeing and treating people for monkeypox, whether we ourselves are contributing to the stigma that they might be experiencing, it exists. And, we should be, from hearing that case, asking about that routinely and asking, who they're able to talk with and, discuss some of the concerns and issues that they're having, and ideally hope that, we can identify a support system and folks that they can, reach out to discuss, some of their recent diagnosis, whatever the condition may be. But it sounds like that's particularly important with monkeypox.
Kind of feel like it gets reinforced every time I come in with a gown and a papper, and it's like, oh wow, I can't be around anybody. You're in a spacesuit, and it's what I'm supposed to wear in there. Unfortunately, we've had COVID around, and that's something that PPE is somewhat normalized, but it's kind of another element where it kind of gets reinforced, like, oh, I shouldn't be around anyone. So kind of, even if you do have a support system, it might be harder to connect with too. Even the case that we're presenting earlier, where this patient was completely isolating from his husband and kind of not physically seeing anybody, and when you're sick and kind of scared about what's happening, and then you don't have anybody to physically console you. It's hard.
So there is a good question in the chat. Should a behavioral health screen tool be used when caring for patients that are under investigation for monkeypox? I mean, I personally would argue that we always should use behavioral health screening tools on everyone, not just monkeypox, because it's so prevalent in society. But I recognize that clinical practice makes that difficult. But I'd be interested to what other hub providers would say.
I agree. It would be great if we could screen everybody every time. I don't know that that's always practical, or that we effectively use that information always in the best way. But I think that, from the discussion today, really how are we talking about monkeypox? How are we hearing the patient's concern? Because even if we see a lesion that may not look classically like monkeypox, I think coming away from this session, recognizing the patient's concerns is really valuable. And, I think that, if they're highly concerned, exploring that further, diving deeper into that, I think would be really important to discuss the fears that they might have. And it may be, not simply doing the right test, but having that conversation about, why they're concerned about it, how they view a potential diagnosis, and who they're able to discuss that with in terms of their sexual partners, but also work contacts. I think that Adam importantly also mentioned the impact that someone would have to be off work for weeks if they have a positive diagnosis, and how do they share that information, or how do we relay that information? I think is going to be important at a stage when monkeypox clearly is linked with certain sexual behaviors at this stage.
Yeah, speaking of work, the Department of Health, when they dropped off his TPOX, met him at work to give him the meds.
While this poll is up, if anyone has any other clinical cases they'd like to share or discuss, you're welcome to open up your mic and talk about them now. You can share them with us via email. Maybe we could use them in the future.
Sandra had a good question about the pregnant partner. So I wasn't caring for them directly, and I understand that everybody kind of moved out of state, but I was able to confirm that both the pregnant partner and the child both got doses of vaccine, but it wouldn't have been within 4 days, so there still would have been the possibility of developing some disease, but I don't have that level of follow-up.
Did you share these results, Jackie? Yeah. So overwhelmingly, it seems like the group is agreeing that yes, we should have behavioral screening. Some said not sure, and some said no. But
I'm curious what folks are thinking of in terms of behavioral screening. Is it simply kind of asking how you doing with this? What are your feelings around it? I mean, I don't think like a PHQ-9 is like the most appropriate thing to administer right here. I mean, it's not, I think I'm just screening for depression. I mean, it's somewhat acute. Yeah, I just appreciate others' thoughts on what that actually means.
So I think just asking is an important piece. I wouldn't do a PHQ-9. All of the diagnoses I've had involve tears. So I think it's not that hard to pick up on it. But even if someone hasn't offered it, they have feelings. So they should be addressed. But I don't think a PHQ-9 is going to help that much. If there's anything, it's reactive depression. So.
We only have about 5 minutes remaining, and I don't have a good answer for you, Adam. But does anyone have any final thoughts, or anyone have any final comments, especially from our hub, before wrapping up? Kat, are you trying to unmute? I can't tell. Okay. I think my final takeaway from this is, just be mindful, use these risk factors that we've had up until this point cautiously, and know that the patients you see with similar rashes, monkeypox, should be popping into your differential, especially in the case of this pregnant lady. Maybe she's not going to disclose that her partner was positive. And we run into this with syphilis all the time during pregnancy, which is why we're seeing a rise in congenital syphilis. So just try to be mindful, try to understand that we do have biases because we know the population that's most commonly seen right now with this, but that likely will change, as we talked about the female who was not sexually active, who did have the rash on the bottom of her foot that tested positive for monkeypox. And Alice had a final question. How long does testing now take to come back? I saw someone answered this earlier. It could be 48 to 36 hours, but I think it depends on where it gets sent and if it's on a weekend or not on a weekend.
Yeah, from what I've heard, Quest is currently processing everything in California. So there's kind of extra transportation from the East Coast if you use Quest as your reference lab, but they're supposed to be able to process it in Virginia in the near future. So that should shave a day off of things. And I don't know if there's any plans to have a more widely available testing kit, or if it's just going to be kind of at these specific testing hubs.
Well, thank you everyone for your engagement and participation. You'll be receiving an email shortly, which contains a link to the session evaluation and to our participant resources. If you're claiming CME credits for today, you do need to complete the evaluation in its entirety. If you're not claiming CME, we ask that you still complete it, as it helps us to continue to improve our sessions. And finally, we will see you again on September 21st when our flash talk will be testing, quarantine, and infection control. And again, if you have a case or a scenario that you would like to discuss, as Adam was able to today, let us know. We do all of the legwork for you. If not, we do have other cases that we will be bringing in, but we love to hear the actual experiences that you're having. And with that, have a wonderful rest of your day, and we will see you in 2 weeks.